Physiology of Pregnancy. Hello, class. Welcome to Flourish Nursing Academy. I am Tutor Godwin. Let's discuss pregnancy physiology. General. Pregnancy produces systemic adaptive changes to support the fetus. Many begin in the first trimester, peak mid-pregnancy, and reverse postpartum. Nursing focus. No normal versus abnormal changes. Prioritize airway oxygenation, bleeding risk, VTE risk, and fetal well-being. Cardiovascular. Blood volume increases by 30–50%. Plasma greater than RBC, which is physiologic anemia, hemodilution. Cardiac output increases also by 30–50%, peaks in mid-pregnancy, increase in stroke volume plus heart rate. HR increases by 10 to 20 BPM. Systemic vascular resistance decreases, leading to blood pressure falls in the second trimester, then returns to baseline by term. Clinical nursing implications. Monitor for supine hypotension, position patient on left lateral or wedge, increased risk for edema and varicose veins. Hypercoagulable state leading to venous thromboembolism, VTE prophylaxis as indicated. Respiratory, tidal volume and minute ventilation increase leading to respiratory alkalosis, PaCO2 28–32 mmHg. O2 consumption increases by 20–30%. Functional residual capacity decreases. Nursing implications. Pregnant clients desaturate faster. Monitor oxygenation. Anticipate difficult airway aspiration risk during anesthesia. Renal metabolic. Renal blood flow and glomerular filtration rate, GFR, increases by 50%, resulting in lower serum creatinine, 0.4–0.8 mdl. Sodium and water retention via RAS. Mild physiologic proteinuria glycosuria can occur. Nursing. Evaluate abnormal renal labs carefully. Treat UTIs promptly. Hematologic coagulation. Red blood cell mass increases by 20–30% but less than plasma, resulting in a hemoglobin decrease. Typical late pregnancy HGB 10.5–12 gdl. WBC increases, particularly neutrophilia. Platelets may fall slightly, gestational thrombocytopenia, but usually greater than 100,000. Clotting factors increase, hypercoagulable state, resulting in increased VTE risk. Endocrine metabolic, placental hormones, human chorionic gonadotropin, progesterone, estrogen, human placental lactogen, HPL. HPL causes insulin resistance. Increased insulin resistance results in risk for gestational diabetes. Screen at 24–28 weeks. Thyroid changes. Increased total T4, T3. Free T4 usually normal. TSH may be slightly suppressed early. Gastrointestinal hepatobiliary. Decreased GI motility and lower esophageal sphincter tone leading to reflux, constipation, nausea, vomiting, morning sickness. Gallbladder emptying decreases, resulting in increased risk of gallstones. Musculoskeletal integumentary, relaxin progesterone, causes ligament laxity, increased lumbar lordosis, and back pain. Skin, linea nigra, melasma, stri, increased blood flow resulting in spider nevi. Uterus placenta, fetal circulation. The uterus enlarges, uteroplacental blood flow increases dramatically. Fundal height correlates roughly with gestational weeks. 20 weeks at the umbilicus. Fetal heart rate normal range, 110–160 BPM. 3 fetal shunts, ductus venosus, foramen ovale, and ductus arteriosus, close after birth, key for neonatal transition. Normal vital signs, lab trends to know. Heart rate increased by 10–20 BPM above baseline. Blood pressure, slight decrease mid-pregnancy, greater than 140/90 after 20 weeks, Chark hypertension. HEB, HCT, mild decrease, physiologic anemia. Creatinine, decreases normal 0.4-0.8 mg/dl. PaCO2 decreases 2832 mmol. ESR and fibrinogen increases. Glucose, fasting tends to be lower. Screen for GDM at 24 to 28 weeks. Nursing implications interventions. Positioning. Left lateral tilt to avoid vena cava compression and improve uteroplacental perfusion. Diet, by 300 kcal day in pregnancy, folic acid, 400 mcg day, start preconception, iron supplementation as indicated. Vaccinations, inactivated influenza vaccine in any trimester. Tdap at 27 to 36 weeks, avoid live vaccines. Fetal movement monitoring, instruct the client to report decreased fetal movement. Common teaching, less than 10 movements 2 hours or significant reduction. Monitor for signs of preeclampsia. BP 140/90 after 20 weeks, proteinuria or end organ dysfunction. Recognize DVT risk, swelling, pain, unilateral leg warmth, assess and intervene promptly.